All right, so here we have, I think, a picture that we remember from before, right? A capillary network. And we know that some tissue needs, I would say all tissue kind of likes to have a constant supply of blood. But some needs it more, like our brain. If we go 4 to 6 minutes without a constant supply of good oxygenated blood, we end up with some brain damage. Our heart, we know, it only takes a few minutes before we start to feel some pain from ischemia there. When we talk about this stuff, let's see, some tissue needs a constant supply. Today on the quiz, we talked about this just a little bit. If this area here had a lot of CO2, let's see if we can write up there, CO2. If this area has a lot of CO2, Tyler, what could we say the levels of oxygen would probably be in that same area? This usually goes with low oxygen. Upper CO2, low oxygen. When we have a lot of oxygen in an area, we usually have low CO2. So Caleb, when we have high CO2, what does that usually mean as far as vasoconstriction, vasodilation? You have to choose one of those words. You have a long time. We have till 10.
Constriction.
That was really close. High CO2 is vasodilation. So when we have a lot of CO2 in an area, we will vasodilate in that area. When we have little CO2 in an area, we will vasoconstrict. Now, this is physiology, and this is what we want. The brain doesn't have to control this. This is just the way it works. This is microcirculation. So when we have high CO2, we already know low oxygen. And this is kind of a pathology, but it's physiology. We're just staying within the norm. What would you say our pH would be? Now we're up to Mike.
I'm sorry, what was the question?
High CO2, what do you think the pH would be like?
You have lower pH.
Low pH, and that's acidosis, right? So let's go with pH, like I said. So if we have high CO2, that usually means in the same area we'll have low oxygen, and our pH will also be low, and that equals acidosis. Now, when we talk about the quiz today, we had when hemoglobin is an area where there's acidosis or low pH, what do we know about the affinity for oxygen and hemoglobin, right? It's probably on the first page. We know that it decreases the affinity. It's also a rightward shift. Some people might have said a leftward shift. The opposite would be true for a leftward shift. So when blood gets here, blood doesn't go here. If we have low CO2, we vasoconstrict. Blood will flow through the path of least resistance and not go here. While blood isn't going there, we will continue to have metabolism. One of the byproducts of metabolism is CO2. We'll eat up the oxygen, lower the oxygen, and poop out CO2, increases CO2. We have increased CO2, we vasodilate, blood comes back into this area that has a low pH. Oxygen and hemoglobin don't like each other as much in that environment, so oxygen jumps off right where we want it to jump off. Goes into that tissue, and now we have well-oxygenated, non-ischemic tissue. Everybody good? That's physiology. That's what's happening in our bodies right now as we enjoy the lecture. All right? When we have a problem with that, some reason our cardiovascular status isn't where it's supposed to be. The autonomic nervous system is what tries to adjust things and make corrections, right? The sympathetic nervous system is usually what we're talking about there. So let's say that we lost 1,500 milliliters of blood, and we're up to Michaela. What in our body is going to recognize that we have a low pressure? Our brain doesn't really recognize it. It has to be told. Who tells it? And what does the meteorologist use to measure pressure? Go ahead. Baroreceptor. So our baroreceptor is located in our aortic arch and our carotid bodies. Carotid bodies, aortic arch. Always measuring pressure. When we get a message like, oh, your pressure's starting to go down a little bit. Let's go to you, Rebecca. Where does the pressure message go to? The pituitary gland. No. What's above the pituitary gland? It goes through the hypothalamus. That's always the answer. It's always the hypothalamus. Whenever something's going to the brain, it has to go to the switchboard of the brain so it gets sent to the right place. When our pressure, you were just ahead of yourself. So when our pressure is going down a little bit, hypothalamus gets the message. It's not an emergency. So Sam, what is the hypothalamus going to do if our pressure is going down a little bit?
It'll stimulate ADH release.
Gosh, that was very quick. Right. So posterior pituitary ADH, the anti-diuretic hormone. Anti-diuretic. So we won't pee. Slowly but surely, our blood pressure will come up. All right. It's the opposite is true too. Our blood pressure goes up. It'll say, hey, why don't we pee out a little bit? We'll lower stuff. We'll be much better off. And then we also have a message that says, oh, our pressure dropped quite dramatically. And then the message goes to the brain stem. So Tyler, what is the name of the nerve that travels from the baroreceptor to the brain? It's not the vagus. It's close to the vagus, one less than the vagus. Glossopharyngeal. So that would be cranial nerve number 9. Glossopharyngeal is both afferent and efferent. Sends the message and goes the opposite way. The vagus is efferent with the letter E. Sends it away, and we'll maybe make some adjustments when we need to change pressure. The vagus could probably help us with that too. But boom, if we go, that glossopharyngeal goes through the hypothalamus, the message goes through the hypothalamus to the brainstem, we're going to get the sympathetic nervous system. And then we're, of course, going to have all of these things that we've listed so many times before. There are the signs of shock. There's what's happening. This one we've seen before, didn't make that big of a deal. Now that we know all about them, we've had them as drugs, we've had them as in the endocrine chapter, we know all about it. So now this is going to be another thing that you'd see on quizzes and tests. When we're in shock, we release our glucocorticoids, improves our blood sugar a little bit, gives us a little energy. It's also anti-inflammatory. And then what happens? So when we have, this is that same picture, when we have adrenaline in the mix, and when we're using our nervous system to cause big old vasoconstriction, what happens in this area right here is this will have a door leading into the capillary will shut and shunt blood back to the core. What is that door called?
Precapillary sphincter.
Precapillary sphincter. So that will be happening. Now, there will also be postcapillary sphincters. They will shut also. There's not a lot of energy there. Who cares about post-capillary sphincters for now? Pre-capillary sphincters shut. We also have a bunch of vasoconstriction. No oxygen is going to go to this area. So what word do we usually talk about then? What kind of metabolism is it?
Anaerobic.
Anaerobic metabolism. So that whole area is going to be starved for oxygen. When we don't have oxygen, we're not going to be able to use that second step of the Krebs cycle, the citric acid cycle. So we're not going to have ATP. If we don't have ATP, we don't have that pump. If you don't have your sodium-potassium pump pumping out the sodium is going to remain in the cell. Michaela, what follows sodium? A rule in nutrition. What follows sodium? Water. So if we have sodium accumulating in the cell, water is going to rush into the cell too. Rush might be a little bit dramatic. Water goes into the cell, and then we kill the cell that way. We also are not going to be using some sort of acid. What's the name of the acid that we put in the citric acid cycle?
Pyruvic acid.
Pyruvic acid. Good job. So pyruvic acid will degrade into lactic acid. When all of this is happening, how is our blood pressure? That was for you, Sam. When all of this stuff that we're talking about is happening, how's the patient's blood pressure?
Be lower.
It should be normal because we're in compensated. This is what's happening when we're compensating, right? We are compensating. We have the stuff here. So we are able to compensate. At some point, we will not be able to compensate. Sometime we will have dead tissue from the water. We will have acidosis. We will have potassium outside of the cell into the vessel. The tissue is still suffering though. We're going to be building up acid, potassium, and we have lysosomes, which are garbage trucks on the inside of your cell that are not very good at saying, this is self and this is not self. It just knows like what's supposed to be inside the cell. What is garbage in the cell? When it's outside the cell, running rogue, it's going to start killing stuff that doesn't need to be killed. All right? Lysosomes are on the outside of the cell now. Potassium is on the outside of the cell. Acidosis, so again, our pH is low. All of that is building up in tissue and migrating towards the vessel. At some point, that sphincter is going to, this one here has been working. Remember, there's precapillary sphincters and postcapillary sphincters. This precapillary sphincter has been working. He's been saying, go this way, go this way. No, stop. Go this way, shutting the doors behind them. This guy over here, postcapillary sphincter boy, he's just hanging out. All right, there's nobody in the capillary bed because he's pushing them all to go somewhere else. So he's not wasting his energy at all. At some point, he fails, and that blood that was all being shunted is now going to come into this area. All right? So blood will engorge in here. The capillary bed will now have blood going through it, and the post-capillary sphincter still is shut. He hasn't lost his energy. He hasn't been burning energy at all. And there isn't shunts in this area. So as blood goes in there and it has nowhere to go, blood is going to stagnate in there for seconds. Blood that stops is blood that clots. All right? So when that happens, you get what's called a rouleau formation, and you're going to have blood clots. All right? And that postcapillary sphincter is going to open up after that. So now what's heading to your central circulation is acid, potassium, and clots, basically, microemboli. Now the blood pressure is dropping. All right? And one of the newer things that PHTLS talks about, the last 2 editions, we've had this before in quizzes, maybe even a test. What is the first sign that you went from compensated to decompensated shock? What? No, it should come after that. Usually the altered mental status is the acidosis and the low blood pressure. Together, you're gonna have an altered mental status. Something earlier. No? Dilated pupils the whole time, what? No, they're probably still tachycardic here. The first thing, again, PHTLS, last two editions, so it's National Registry that they could use this for sure. And they almost always use this. PHTLS, ITLS use the same word. A precipitous drop in your end tidal CO2. Now remember, when you're taking care of the patient, you have them on your monitor, you're not getting a constant blood pressure, right? So nurses sometimes have constant blood pressures and invasive. We have non-invasive blood pressures. So if you have it set to every 5 minutes, it cycles of blood pressure. Every 5 minutes, you know what the blood pressure is. You don't know what the blood pressure is right now. You just know it was this a little bit ago. End tidal SU is end tidal SU. No. The end tidal CO2 is constant, second to second. All right, breath to breath. So you're always getting the numbers. Even second to second, breath to breath. So now that's the first thing. As soon as you see again, I'll bet you the National Registry will use the term a precipitous drop in the end tidal CO2. Push your NIBP, and that might be low now too. Or in the next 5 minutes, that's where your blood pressure will lower. It kind of doesn't make sense. You have to kind of trust me on that. You can Google it and read all about it if you want to. But to me, it seems like when all this opens, CO2 will be returning to the lungs, and so it should be a precipitous increase in end tidal CO2. But overall in your body, you have decreased perfusion, and end tidal CO2 and perfusion go together hand in hand. All right. So a precipitous drop in your end tidal CO2, hit your NIBP. It's probably what we should think as paramedic students is your blood pressure is going to be lower. All right. And it soon will be lower if it is in an immediate way. So the next thing is mask pants, all right? And mask pants, I think, are a good example of how poorly we use research in EMS, all right? So the military does a pretty good job. What did the military think of mask pants in the 70s? You guys have any idea? They loved them, all right? MAST, what does MAST stand for? Anybody know? It's changed a little bit over the years, but they're military anti-shock trousers, all right? Some people will call them medical anti-shock trousers. Now, PASG is pneumatic anti-shock garments, all right? The person who invented this is a flight surgeon, all right? And he said, holy cow, these flight suits, if you drive jets for a living, like an F-14, your cool little uniform thing, that zip up, that isn't like what nurses wear. That it looks like it, but on the inside, they have ability for air to be pumped into their suit, all right? When they're in there, you can see this, if you watch, you can see it in movies and such, they plug that into the airplane. And when you start to throw G's against your body, that will increase the amount of pressure in your flight suit. And the flight suit will push the blood back up into your core of your body so you don't pass out. Make sense? We've understood this since probably the 50s, all right? I think the flight suits are a 60s kind of technology. So the flight surgeon said, hey, that would work for people who are in shock. What we can do is push the blood from the lower extremities, push that back up into the body, and they'll have a blood pressure again. That works. It actually works. It works for a pilot and it works for your patients. If you put mask pants on somebody and pump up the legs and if you want to pump up the stomach, you will increase their blood pressure. 100%, I believe that. It absolutely is, to me, axiomatic. We don't not use mask pants because they don't work. We use mask pants because we don't know how to use them. All right? And it is us as medicine, not just as paramedics. So when you put these on somebody, you should say, boom, we're gonna push blood from their extremities up into their abdomen. If we increase the abdomen, we're gonna increase the pressure in the abdomen, and blood will stay here to here, right? So the thing is, what we all know from our IV lectures is, do we want to increase a blood pressure for somebody who's bleeding to death internally? No, we don't want to do that, right? We don't want to, if somebody has a chest injury, somebody has an upper abdominal injury, you put mask pants on, you're going to increase the pressure, you're going to increase the bleeding, so that doesn't go together. We used to use mask pants, and we would use them like every week, maybe one person would have used a pair of mask pants. So they weren't rare, and we never would use them. I put them on maybe 10 patients in 10 years or something like that, and by that time we didn't use them anymore. And when you would put them on, the patients you put them on are people who have super low blood pressure, more than likely from trauma. Sometimes it might be a septic shock or something like that. Who knows, whatever other reason. We might not be able to see any veins when we're trying to start an IV. If you put mask pants on, you'd be able to see their veins. Sometimes you saw changes in LOC. You definitely feel like their blood pressure's better, all right? Or, whether that was you checking blood pressures, but they just look different when you improve it, like their color gets better or whatever. The reason that we stopped using them is two flawed studies, really they are, from Texas and New Mexico or Arizona or something, where like one of the ambulance companies used mask pants and the other company didn't use mask pants for a month or 2 months or whatever it was. Don't hold me to that one. And then they compared the data. They didn't compare like how badly they were injured. They didn't compare any of that kind of stuff. It was like people who got mask pants and people who didn't get mask pants they didn't really watch anything else. And the people who didn't get mask pants survived more. Does that make sense? So could have been the patient population, and there's not big numbers there at all. But since that got in, and then like all the states demanded you have to have mask pants, that went away. Nobody complained about, none of the owners of ambulance companies complained about that because they're about $1,000. So they're like, all right, we get. And you bring them to the hospital, sometimes they cut them. And so that's $1,000 cut. You cut the tubes, cut the things. Now you have to replace the mask pants that are $800, over $1,000. You can get them still on eBay. So what you need to know is they do work. And so we're National Registry students, right? So that's what's important. There still is an indication for them, all right? And that indication is pelvic fractures and low blood pressures, all right? So you can do it up here. It says stabilize fractures of the pelvis and bilateral femur fractures. That completely makes sense. What you'll see at the National Registry is either it'll say unstable pelvis. You just have to go with pelvis fracture and a low blood pressure. We shouldn't think of mask pants as we'll stabilize your pelvis. You'll feel better. It'll make you happy, and that's not what you use mask pants for. You're using mask pants that usually give somebody back their pulse. All right. So they have a real weak radial pulse. You check their blood pressure. It's 80 over this. This is crunch. I think we can go with bilateral femur, like as far as the concept, but on the National Registry, it's a pelvic fracture. That's a mask pants. Mask pants work for that. We should realize, boom, that totally makes sense that mask pants would be good for that. Pelvic binding is good. Increasing the pressure of the abdomen so you bleed less in your abdomen, that totally makes sense. Stabilizing the pelvis, all of that makes sense. Giving it to somebody who has a good blood pressure starts to not make sense. You're increasing blood pressure just so they bleed out. Here, what it's good for is giving them a pressure just so they're perfusing their brain. And when the military used mask pants, the way they used them, Army medics didn't walk around with a big pair of mask pants in their backpack, all right? They would be on the helicopter. And so when they would put the patients on the helicopter, one of the medics would put the mask pants on and inflate them, all right? If they didn't get put on the helicopter, they got on right when you got off from the helicopter when you're being triaged. If you can remember MASH, all right? That was Korea. But they would put them on, and then they would go not into an ER, where a PA looks at them for a while and they order a bunch of tests. They go into the OR. They start 2 IVs and they take the mask pants off. Mass pants were never made to stay on for longer than like 30 minutes or 45 minutes. That's it. It was just enough to where now they're perfusing stuff. Now it's easy to start an IV, and then we go right into surgery. All right, so completely makes sense in those, and that you can use them. We would use them for non-surgical emergencies like septic shock. They would work for septic shock. GI bleeds, which is kind of a surgical emergency, it would work for those too. So if you have a bunch of bleeding in your lower extremities, mass pants might be a good idea too. Lots of cushions, I should say dressings, and then mass pants around that kind of gives you that circumferential pressure. Always, ever since they made them, it's always been an absolute contraindication is pulmonary edema, because there were 4 people who had low blood pressures, but another way to say pulmonary edema is cardiogenic shock. That's where they're going. All right, these are bad for cardiogenic shock. If they're going to ask you a question about mass pants, it's more than likely going to be a critical thinking kind of question. So it is, do you understand, like, mass pants would be terrible. You would never put them on somebody with cardiogenic shock, because you're just increasing afterload, increasing systemic vascular resistance, and that's absolutely what you don't want to do for somebody who has left-sided heart failure. Relative contraindications was pregnancy. You wouldn't inflate the abdomen. Penetrating abdominal injury and evisceration, they're probably bleeding out there, so it makes sense. You don't want their pressure to be great. Groin injuries, they'll be in the way. So if it's spot on, just the groin injury, you might want them because they're in the way. Major head injuries, you shouldn't be thinking, hey, if this guy's got a head injury, get me the mass pants. And the last one is, the weirdest one, is a transport time of less than 30 minutes. And the idea behind that is it takes so long to put mass pants on. And that is absolutely not true. That mass pants can be very easy to just slide up over the patient, tighten them up, and inflate them up. All right, it's not hard. It's not a 2-minute operation. You can do it less than 2 minutes. It's super easy. So you just can't be ginger with the patient. You're just like, let's get these on. If you're doing it that way, it's pretty easy to get it done. And Reboa, you just need to kind of know what Reboa is. You're not going to need to do this. This isn't going to be a skill station. But nowadays, something that the military has kind of perfected, and now like Butterworth, at least Butterworth is going through, that's long. I'm sure Butterworth is through, and they're accredited. They can do a Reboa. I would think Saints and Metro probably can do it now. When you have really bad trauma from here on down, about the same place where mass pants are good. When you have really bad trauma, what they do is they do like that cardiac cath thing into your femoral artery, which goes up into your aorta. And they just put this balloon up. They have the choice to go north of the kidneys if they think your kidneys are bleeding. But if they want to perfuse your kidneys, they just blow this up here, and then no blood is going south of the thing. All right, so now all your heart is perfusing is your chest, right? Everything, the diaphragm is like about right here, so you're not perfusing that much. I think you might perfuse your liver, is that right? You'd be perfusing your liver. But then for all of that trauma, again, it's a military thing. A big part of their death was junctional hemorrhage, people getting their legs blown off. Reboa is super awesome for that. But they're using it for all of the things where you're bleeding bad, south of where that balloon is. They now use Reboa, inflate it, and they have 2 hours to fix all the damage. Do, what is that called? Something sort of surgery, meatball surgery or whatever, or resuscitative surgery, just to get them back to where they're going to survive, and then they do the rest in a more controlled way.
Confirm the balloon placement above or below the kidneys?
What's that?
How do they confirm the
X-ray would be, they measure, it's a measurement type of thing, but then your X-ray, I would guess. And then, but it is just a measurement thing, like stop here or stop there. All right, so let's talk about this. Now these slides, the next few, we've seen all of these, really close to these anyways, in the hematology lecture. So now for quizzes and tests, straight on questions right from hematology, all right? That have to do with clotting and maybe a little red blood cell, hoo-yah. So when we have an injury to a vessel, and again, this is the term that they like to use now is this is the extrinsic pathway, right? Intrinsic pathway is stroke and heart attacks. Extrinsic pathway is trauma. When a vessel is injured, immediate vasoconstriction, that happens just boop, just immediate. The other thing is to remember is all of those arteries are kind of stretched, so if they're cut across, they'll snap back, and then usually, I shouldn't say usually, some other word like matter of factly, muscles that are traumatized are muscles that inflame. So muscles will inflame, and that helps also stop the flow of blood. So they contract, they constrict, muscles will grow around them. So hopefully all of that's helping control blood loss. Platelets get sticky when platelets are feeling turbulence. And then we start the clotting cascade, which was all about prothrombin, turns to thrombin as long as there's some calcium in the mix. And then we need a little bit of vitamin K, and we can change fibrinogen to fibrin, right? So that's all this stuff here. Again, so you guys, you can probably forget about calcium and vitamin K. Just realize they're part of the mix, right? Calcium and vitamin K, and remember you need a healthy liver for vitamin K. But here, prothrombin, where is prothrombin located? In your bicep?
No.
What does TPA stand for? What does TPA stand for, Tyler?
It's full of blank.
It doesn't have anything to do with prothrombin, but it sometimes helps me remember. All right. Tissue plasminogen activator. And so plasminogen and prothrombin are in the tissue. All right. In the tissue, prothrombin to thrombin, fibrinogen to fibrin. All right. And fibrin is the actual net that captures stuff and causes us to have a clot. As soon as that happens, our body starts to shave down the clot. All right, we form a big clot, and then our body right away starts to say, hey, this is a big old ugly clot. Blood is not getting through here very easily, so we need to do something about that. And it starts to break down, shave down the clot. It doesn't want the clot to go away, but it wants to shave it down and make it so blood gets through there easily. And that's where that plasminogen comes from. And remember, tissue plasminogen activator. So plasminogen is in our tissue, all over our tissue. As soon as we have this clot, we start to get that plasminogen to become plasmin, and it starts to knock down the clot. So now, one of the newer drugs, for us anyways, is TXA, tissue tranexamic acid. So tourniquets aren't going to work on, the box, in the box breathing or bleeding. So when we have a non-compressible wound, we can't use tourniquets. The only thing we really have that's kind of in our toolbox and something that kind of works is TXA. TXA is supposed to be given early. It's proven in research. The earlier given, the better or more impact it has. Very little detrimental things happen. There's big studies, big numbers. It seems pretty good to go. It should be given within the first hour. Starts to have less of a efficacy after that. It's been given in Europe, you can get it like for menstrual bleeding and things of that sort. It's like, I don't want to say over the counter, but it is something you can go to the pharmacy and say, my doctor wants me to have this, and then you get that. All right. So there's big numbers, and the idea, when I would think about this, I would think, well, there's going to be this chance of pulmonary embolisms and strokes, which are there, but it's like 0.2% or something like that. So a low number of that complication of you having clots that are going to be more stable that you don't want to have. So two major studies, both are pretty good, and there's a lot more than that nowadays. That is, the slides right here are from TCCC, and that's an old slide. That's at least probably 2012. By then, they'd already had those two supportive research things. So again, degradation of clots. How does it happen? Plasminogen is the inactive form. Where is it located? In the tissue. It migrates in, it's converted to plasmin. Plasmin is going to be like a Drano. It's going to let's clean this place out. TXA makes that so that pathway doesn't work. It doesn't allow plasminogen to become plasmin. And so it preserves that fibrin matrix so we have a better, stronger clot. We then bleed less over a long period of time. Those are what we talked about before, and here's what we're talking about now then. We have the same slide in hematology, and that's where TXA works. The way we give TXA is on the next slide. So here are some of the adverse effects: is nausea, vomiting, diarrhea, orthostatic reactions. There is a theoretical risk of increased thrombotic tendencies like DVTs, and we should probably worry more about like pulmonary emboli and strokes. But the numbers just aren't there to where it should be a big concern. Contraindications are severe renal insufficiency and hematuria, and that's not really something for us. Like we wouldn't, for us, we should know like the person is complaining of bleeding blood. We shouldn't say, get some TXA in that guy, all right? That's not gonna be a thing for us. It's just not there, all right? We don't have to worry about that. And renal insufficiency, if we're talking about, we would never give this to somebody who has had, what would you call it, dialysis. That's probably not a big deal for us. Not bad things to remember. It seems true in all of that. But when we're giving it, it's usually, we don't have that information from the patient. It's a bad trauma and we're giving TXA. As far as the military goes, if you got shot, if you get near something that blew up, you're getting TXA early on, all right? So when you're taking care of Marines and Army guys, they don't hang out with a lot of renal insufficiency problems. They're just not there. And you're not going to be asking about hematuria and things of that sort. The last thing, and probably what we need to know then, is you're going to have a gram of it. We're going to mix that in a 100 bag. And we're going to administer that over the same as all the other drugs that we do this with, over 10 minutes. That patient may, even when you're doing it right, react by having hypotension. And if they have hypotension, they want you to slow it down. All right, it's not stop it, it's slow it down. All right, so when you're giving TXA over 10 minutes, if the patient's blood pressure drops, and this is kind of tricky because you're giving it to a patient who was shot or blown up or whatever, bad car accident for us, and their blood pressure could be going down because they're going from compensated to decompensated. But no matter what, when you're giving TXA, after you start administering it, their blood pressure goes down. The go-to is slow your TXA, right? Just slow that administration down. And again, one of the good wrong answers is stop it totally. It doesn't ever say stop it totally, it just says slow it down. Then administer crystalloid or blood products per your protocol. And then for today's quiz, we had one question that was, everybody got it right, what fluids do we give? And we give normal saline, all right? Normal saline is what, generally speaking, what everybody is giving nowadays. Pre-hospital, the other solution would probably be Ringer's lactate, which has some importance, but Ringer's lactate has a little bit of potassium in it. And if you're hyperkalemic, you might want to avoid Ringer's lactate. But it also has some things that help with intracellular acidosis, so you may want to give Ringer's lactate. When you're giving blood, you don't give blood and Ringer's lactate together. So that's one of the arguments that we should have normal saline. on a Y tubing or a blood tubing. As soon as we get to the hospital, they can spike a bag of O negative and be running blood sooner. The other drugs or solutions that were in that were the wrong answers were plasminate and maybe dextran, and there's another one that's HEC. There's hetastarch, and then Hextend is what the military is using. And all of those are either going to be a big sugar molecule or a protein molecule. What is the classification of those solutions? If normal saline is a crystalloid, what are those solutions called? What is it? No. They more than likely are hypertonic. But if you could say like the crystalloid and colloid. So those are colloids. So when you're given a big sugar molecule or an albumin protein type of thing, those are colloids. And generally speaking, in EMS, we don't give colloids, all right? But this Hextend is one that would represent, we should maybe be giving it, all right? So when you give those colloid solutions, the theory behind it is, if this is your vessel and this is your tissue, when you give, let's make this a big sugar. When you give Hextend, plasminate would be the other one, dextran, all of those are possibilities. Some of them are just like they're going to mimic plasma better. And so plasma has protein. Our plasma in our body has protein, has some substances in it. So they make that more of an equal type of thing. But when you're talking about Hextend and dextran and albumin is a big one, water will be pulled in to the vessel from your body. So this is tissue here. So when you give, and remember this question, this factoid was in your quiz too. When we give a liter of fluid, 1 hour later, only 1/3 of that fluid is still in the vessel. Otherwise, all that fluid goes out into the tissue, right? So when we give a liter of fluid right away, it will increase the vessel size by having a liter. However, it will also immediately start putting fluid into the vessel, outside of the vessel, interstitial and into the cells. Everybody get rid of that? When you give these others, the colloids, as far as we as paramedic students should understand this, is now we can give, for Hextend, I think it's 500, right? So we can give 500 and it will pull fluid out of the body and put it into the vessel. So we will have a bigger bang for your buck, so to speak. However, that might make sense where you just want to increase the blood pressure, right? Who wants to increase the blood pressure when they're bleeding out from the vessel? So then it starts to not make sense. The other thing is we're trying to take care of the patient as a whole. And if we're robbing them of the fluid at the interstitial and intracellular, we are actually, if you can remember like the third slide, where we're talking about all the bad juju that happens in the tissue, where we have anaerobic metabolism, you can make an argument that that might be worse because now we're also pulling the fluid out of that area. Does that make sense? So usually when we talk about Hextend and when we are worried about the National Registry, first fluid, at least your first liter, is going to always be normal saline for us. But that second, the second IV that you start will be normal saline again, but then you'd hang Hextend with that, all right? And send that in. Make sense? We will always hang salines. And then something else will go in. Because then when we don't like it, we just stop it and we have a saline run. Go ahead.
What does INR mean?
International Normal R.
Blood, right?
What?
It's for your blood.
It is. INR, you don't need to know the number, like 1.5. INR is International Normal Rate, I think, and it is the rate at which you clot. So it is coagulopathy there. And so this is another thing that the military talks a lot about, but it's in the PHTLS stuff. It's not in your book, I don't think. And this is the trauma triad of death. So where you see it a lot is critical care medicine, flight medicine, nursing, trauma, TNCC. TNCC. That's where they talk about this more. So I would think, since it's in PHTLS, it's got something we should pay attention to. It's not a big deal. You don't have to memorize these numbers at all. We know what pH is supposed to be, right? So, and this is 95. So what they say, basically, might say there on the slide already, 50 to 90% mortality when these are a factor when you're talking about a trauma patient. When they're hypothermic, when their pH is below 7.2, or their INR is above 1.5, above. So this is a time thing, there's a rate, so it's taking too long to stop bleeding, all right?
People on blood thinners, is that INR just kind of assume that it's higher than 1.5?
Yes, yeah, we just have to assume, yep, and we don't have to remember the 1.5 at all. We just have to say there's a coagulopathy in play. So again, with the pH, we don't say, oh, his pH is, because we don't know that kind of stuff, right? This is more conceptual for us now. Even small decreases in body temperature will interfere with blood clotting. So this is the one that we can make an impact on, right? We can't really change people's pH that well. We're not going to be giving bicarb for this kind of stuff. We can make sure they're breathing and ventilating. That's the important thing, all right? And then we're not going to be able to change their coagulopathy, really, like, hey, we're going to now start giving, the reversal agents for Coumadin or whatever. What's the reversal agent for Coumadin? Vitamin K, I think that's right. So when people are in shock, they don't generate heat and they trend towards hypothermia. We learn that as EMTs, I would think, right? We're supposed to keep people warm. So what the military now is sold on, in TCCC, they would teach this a lot. This is basic, is get them out of their wet clothes and get them into something warm. So they got this whole thing, like it's a big old Mylar sleeping bag, thick Mylar sleeping bag that is all Velcro, so you can open it all the way up, put the casualty in it, cover them with a little bit of a sheet, and then they got like a big old 6-panel hand warmer that goes over his whole body, and then you close up the whole system, so he stays nice and cozy warm, all right? So the very basic stuff for us, and it is one of those things that we should be paying attention to, watching trauma patients go in with nothing over the top of them, all right? They're completely naked in Michigan on a backboard going in, or just a sheet that's very often wet as they're going into you're like, that is wrong, all right? It completely makes more sense to wrap them, especially in the cold winter months, which is October through April here. So we, put a big blanket down, put the patient on top of that, wrap them up, and then another blanket over the top of that. Keep our trauma patients warm. It's the only, from the triad of death, there is no other triad or cool shape of death in trauma care, right? These are the things that they have noticed that when they're present, people die more often, and we should try to control those. The only thing that we really have as paramedics and EMTs is keep them warm. Warm the back of the ambulance up in a big way, and then wrap them up with as many blankets. Make sure you have blankets on the ambulance. So when they get down to 95, what do people usually do when they're at 95? Shiver. So we should never have shivering trauma patients. So 50% of serious trauma shows up in the ER hypothermic. Half of them are hypothermic. That number doesn't go with the 95%, 95 degrees, but it is just hypothermic. We need to know hypothermia increases coagulopathy. We bleed more when we're cold. All right, it's not like blood freezes and we stop bleeding. If we bleed more, it doesn't make sense, because when we're cold and vasoconstrict, it should be good for us, right? But it isn't. Cover them with a blanket, warm them up. Warm IV fluids is another way to go. Acidosis is way down by a pH of 7.2, which is dang acidic, all right? So again, we don't have the ability to measure this, so we should be thinking like, what can we do? Do you guys remember, what is the pH of IV fluids? What do you think it would be? 7.3 or 7.2? What do you think?
I do not remember.
And Caleb? Oh, that would be cool. Look at these. 5.6. 4.5 to 7.0, it says in the parentheses. They're like, we don't know, something like that. Depends on like who's doing it. You know how Fred can be. And then this would pH of 4.0. All right. And then here, 4.5 to 7.0 again. So the thing is that it's not axiomatic. It's not a perfect, like, we're giving the person acid. All right. So because it does change when it's in the body, so it's not quite, the reason for that is it's the preservatives and such that's giving you that. It lengthens the shelf life of the fluid for it to have that pH. And it isn't causing acidosis. So don't think that, oh, I'm giving them acid. But at the same time, in no way should you say, let's give them fluids. That will help his acidosis. That absolutely should not make any sense in our brain. Fluids doesn't correct it. And you could see that it could possibly like, oh, I could see giving somebody a whole bunch of fluid, they would trend towards a low pH, not an increased pH. And the last one was the coagulopathy. And so that just goes with what all of our training is now, is we need to ask about those medications and report those medications and ask about bleeding disorders and things. And that is one that brings anybody like, oh, okay, you're a fall from the floor level, but you have a pretty significant, let's go with a change in mental status, and you're on Eliquis. Boom, you're a priority 1. All right. Everybody good with that? Bad mechanism of injury with Eliquis. Boom, you're a priority 1, just like that. That's from that triage criteria, right? Once they're on, that's a big thing. It was anyways a few years ago, a big thing for our protocols and our education in this area. And it's true all, for National Registry too. So we need to think, oh, Eliquis, that's a priority patient. That's probably what they're going for the National Registry. There's a picture of old people's skin. I'm going to go through these. Okay, right, not too fast. We're doing well. That's the skin. You have to remember all of that stuff. And then here's your closed injuries. You need to know what a bruise is. A hematomato there is when you actually have like a collection of blood that you could understand, like, oh, look at that blood. I could pop it and blood would come out, all right? Ecchymosis is more like all scattered through the whole thing. You're not going to be able to pop it and blood's going to leak out. And then a crushing injury is more about mechanism of injury. If I tip this over, left my foot here, it would crush it, all right? That's a crushing injury. And then there is crush syndrome. So with crush syndrome, what has to be true then? How do we create a scenario for crush syndrome?
It's like an extended period of time.
Yeah, any ideas for the extended period of time?
4 hours.
4 hours. So that's probably right out of our book, right? So 4 hours. When we have something for 4 hours sitting there. So what other time frames have we heard when we're talking about trauma care? What other time frames have we ever heard, like associated with tourniquets, let's say? Is there any time frames that we worry about or think about or part of the training?
90 minutes.
90 minutes, 2 hours, all right? So 2 hours, if the way they generally feel about it is if you have a tourniquet on for 2 hours at the hospital, then take the tourniquet off and not worry about the patient too bad, all right? Once you're into 4 hours, when you take the tourniquet off, you should be a little worried about the stuff that was in the compromised leg, let's say, all of that bad juju. So we know all of the bad juju that we talked about so far, plus what? What else when we tourniquet something off? We have potassium, we have low pH, we have microemboli, and there's one more thing when we have a crush. What is that?
Blood clot.
No, that's the microemboli.
Acid.
That's the pH. It's myoglobin, all right? Traumatized muscle releases myoglobin. When myoglobin gets to our kidney, what do we call that? Rhabdomyolysis, right? So when we're dealing with a crush syndrome, we should realize that if it's been 2 hours, stuff is accumulating. If it's a crush and there's a lot of area crushed, he could have a whole bunch of myoglobin, more than a tourniquet on something else, right? It's just a tourniquet. 6 hours as it becomes now like, oh, we should just amputate, all right? It's too dangerous to release this. There's too much of that bad juju stored up. Michaela, give me a scenario where somebody has crush syndrome. Rebecca, you're on deck. You're going to have to make one up. And Sam, you're next after that. Go.
A farmer, let's say falls off the tractor and gets run over, and he's under the tire for a while and nobody knows he's out there. Oh,
What do you say? I don't know. That was a really good one.
okay.
So, a farmer under a tractor tire.
A mechanic that got crushed working on a machinery.
A mechanic working on machinery. When you think of mechanic, what kind of machinery are they usually working on?
Well, I was thinking like big, like industrial.
Oh, an industrial
Because
mechanic.
that's what happened at Hayworth.
Okay, good, at Hayward. So now we have a full good story.
Like an explosion causing a building to fall and collapse on someone.
Those are all good ones. So you think those are all good ones. So now, in all of those situations, you can think, when we have I like the building one, so we have pieces of big concrete and such on our legs. Is that going to compromise all the circulation to the leg? Could that compromise? It could, right? Remember this, what is this test called? If I go like this, and like this, and like this, what is this test called?
And you're pulling stuff out from like.
This is called the Allen test, you don't have to know that. So when I go like this, I'm still stopping, but then when I lift up my ulnar side, hopefully, it returns, right? But I still had this one compromised, so my radial wasn't. So that's true, like when you have whatever we can think of crushing our leg. We may have some circulation, but it's limited circulation. We still have all of that rubble all over and all that trauma to our muscle, releasing myoglobin. We have all of the stuff that we have from shock. So it's hard for us to, as paramedics, say, this is what we have to do. This is, of course, what the patient has. We kind of have to make a guess. Can anybody else think of another one that they don't even call crush syndrome anymore? Or they don't call it crush syndrome, but it does all the same stuff. It's called suspension syndrome, all right? And so that's usually then associated with like window cleaners. And they fall in their harness, and they very often have it completely tourniqueted, all right? So they have less myoglobin from traumatized tissue, but more of a chance of a complete tourniquet stopping all of the blood flow because it's tendon all the way around a vulnerable area of their leg. Suspension syndrome. So that could have been a firefighter, it could have been some guy who was just climbing rocks and rappelling, and it could be probably when you'll see in the National Registry is a suspension syndrome from a guy cleaning windows. So those guys, they made it easy in 4 hours. They're all 4 hours. Suspension syndrome, in reality, you read about it, it can be much less than that, down to 2 hours, and they can have no blood flow for that period of time. I don't know why it's so much worse kind of doesn't make sense to me. So what do we do when we get to that guy, that farmer who ended up underneath his tractor tire? And the tractor tire went right over his pelvis. Seems like his pelvis is kind of intact because it's soft ground, but he has not been perfusing his legs for 4 hours. What does our book say to do or curriculum say to do?
Maybe a sodium bicarb and a bunch of fluids.
Let's start with a bunch of fluids. How about, right? So fluids. What else is true? So fluids, and we're talking 1 liter, 2 liter, 3 liters of normal saline. And we're not doing that because of their blood pressure. We're just doing that. Why are we doing that? That's a good question. Dilute. And why are we trying to dilute? Was that
The shock to the system.
not the shock to the system? It's one organ that we're protecting. Kidneys. So it's called kidney protective, or a renal protective measure is to give 1 liter, 2 liter, 3 liters, you choose. All right. And then another thing that Caleb mentioned is sodium bicarb. The sodium bicarb is to treat what? And high potassium. All right. It's really potassium. Like when you read about it, they focus on that. But this guy could be acidic too. Same all of this stuff. What else? This guy's hyperkalemic. So what else is in the recipe? If we see cardiac irritability or widening QRS, so runs of PVCs, multifocal PVCs, QRS is starting to widen now, we treat the heart with calcium. So here, we wouldn't just willy-nilly just go, give him a gram of that, throw some more electrolytes in there. We would want to see evidence. Irritated heart, widened QRS, peaked T waves. With that irritation, we might think calcium, right? Albuterol, for some dang reason, pushes potassium back into the cell, all right? So albuterol, no wheezing, didn't have to wheeze it off, you just give them albuterol. And then one of the last things is insulin. So insulin may be on a helicopter, it may be on that. Call a physician and have him come in because we have that much time as we trying to get this rubble off from him. If you're going to give him insulin, what other drug do you think you give him? Yeah, dextrose. So if you're going to give that, so these things here, along with pain control, are all crush syndrome drugs, all right? And what they want you to do is give these things before you lift them, lift the piece of machinery from Hayworth off from the person, before you have the firefighters unentangle him. So we at least start an IV, I think from my perspective, I think a good way to go is start the IVs, fluids are wide open, and do a cardiac assessment. Do a 12 lead on the person if you have that ability. That gives you your orders for, your basically your marching papers for whether you want to start going down the sodium bicarb, albuterol, all of that kind of stuff. If you're seeing peaked T waves, then you start moving towards sodium bicarb to treat, really you're treating hyperkalemia.
Does it matter pre or post entrapment?
And I would say
And they've got them out, but it was a prolonged entrapment.
you still treat, yep. And I would, I think part of the thing is, part of like the theory of this, and like, now I think we're making up stories when we talk about this, is you'd say, don't get them up, don't free them up, all right? Let me give them 3 liters of fluid, do this. It's probably not gonna happen. In reality, people want to get out from underneath the thing. The firefighters are all salivating, trying to get them, they get to use this equipment. So you're gonna be lucky to get the IVs going and then do a good, I think cardiac assessment just is a judicious, good way to go. We're not just gonna start shotgun approach to just give them all these drugs. So get that done And I think what's gonna happen is they're gonna lift that thing off, and you're gonna be treating what you deal with, what we're dealing with. What else could be? We're back to, Michaela's, the guy has a big old tractor tire like this that's been setting on his mid thighs, just right here now. What else could we do before the firefighters get on top, start that thing and just roll it off of them? Tourniquets. All right, so that's also totally makes sense. If you tourniquet them, both sides, all the way to where they don't have good perfusion, now it's the doctor's problem. All right, so and it's a doctor's problem, especially if it's been less than 4 hours. Now they can undo the tourniquets and then turn it back and put it back on. Undo them, put it back on. Undo them, put it back on. And in between there, look at how well is your body absorbing all of this bad juju. All right. When you get a leg replacement, a knee replacement, hopefully your old leg doesn't get taken out, but when you get old, you need to get your knees replaced. All right. They've been doing that surgery for a while now. And what they do is they tourniquet your leg. All right. They tourniquet it. And I believe that they can just keep that tourniquet on for 2 hours. All right. And if that surgery, let's go with 90 minutes. Can I give you a safe area there? So once they get to that 90 minutes, they have to let go of the tourniquet. All right, then they have to make you bleed. So they'll give you blood and let you bleed for a little while, but reperfuse your thing. And then they'll say, let's start, while they're in surgery, start drawing your blood and seeing how, what kind of problems are we dealing with. Because you can draw myoglobin levels. You can draw, how well are your kidneys working, blood and creatinine levels. We can check all of that kind of stuff. Red blood cells, white blood cells, all of that stuff can be checked. And then we have an idea of like where to go. Let's give them more fluid. Let's give them more blood. Let's give them some sodium bicarb. All of that if the problem goes on for too long. So doctors, nurses, all the specialists have a much better way of treating this than us. Shotgun approach. The only thing we can do is give these things. There isn't really, like in the hospital, there's not magic fairy dust. All right, they're going to be doing about the same thing. All right. But the patient will also be under propofol, all kinds of different things. They can do it over a long period of time, drawing blood, more surgical approach. Good with crush syndrome. And then compartment syndrome is usually associated with like a calf or a tib-fib fracture. Your muscles of your calf expand more so than the fascia does. So that increases the pressure within the compartment that the muscle is in. And when the muscle grows too much, it cuts off the blood supply. And so you have increased pain that was worse than when you fractured it earlier or when you injured it earlier. And what do you think they do? A fasciotomy. Yep, they cut it and lets that expand. It hurts so much that they usually don't use lidocaine or anything. They just cut it.
Just like a hot dog.
It blows up. All right, and then here is abrasion. You need to know what that is. A laceration. What caused this laceration, do you suppose? Bolt prop, you think? Seems like it. So let's pretend this is some guy who was on some sort of agricultural equipment, all right? And it augured, he got his leg caught in an auger when it was going around like this and it sliced it like that. What would we do for that patient? This patient, that's his only injury. He's smoking when we get there. God dang, augers is the third time this happened this year.
ABD pads and rapid.
What's that?
ABD pads and rapid.
ABD?
As long as it's not like bleeding profusely. I mean,
It's just that much. Like, I don't see a lot of blood.
ABD pads are. We've got paper pillowcases that sometimes when people's legs are leaking, we just put it over their leg. And
I don't like to talk about leaky leg syndrome. So this is one of those things for me. These wounds we clean. All right. This guy's not going to bleed to death. That's where it becomes confusing in the EMT mind. If they're gonna bleed to death, we don't clean the wound. We wrap it and pack it and get to the hospital. But this kind of stuff, if you have tap water is fine. If you have your water, like now I work for Rockford. I've already done this a couple of times. We have to, my partners. I like washing these wounds. All right, I like doing. These are my favorite wounds. These are my favorite calls now because we can make an impact. The longer, remember, this is an auger from farm equipment, not a boat prop in the water. So there's all kinds of bacteria in this wound, and there's absolutely no way that you can argue getting that out of the wound as soon as possible is best. All right, it's within hours you have noticeable growth of bacteria. All right, and if this isn't as main, and if you just cover it and don't show anything, and then it's in the hospital for a while, there's definitely going to be an increase. So guess what? Which antibiotics for that? Nobody, he's not going to die. All right, so I am not telling you like if you do this, you'll save a life. It's just not going to happen. But what I truly feel is you will like your work better if you always do your best work. All right, and if you look at American Heart stuff, Red Cross stuff, National Safety Council stuff, SOLO, which is the wilderness stuff, it says for first aid, if you have this, take time and clean it out. It wouldn't say that if it didn't matter. It's research driven, all right? And it's not Johnson & Johnson, this is why you should put a bunch of goo in it. It is, the earlier you clean it out, the better the patient is as far as getting better quicker, the wound healing without bad scarring. The other thing is your reputation, you're gonna be paramedics. Your reputation amongst the EMTs will be better, all right? If you're taking this small stuff and now you've cleaned it out, you've spent 10 minutes on scene maybe, cleaning it out, putting sterile stuff over it, bandaging it nicely, and I like the idea of something over the top of everything, like a paper or cloth pillowcase. And when you turn the patient over to the nurse has seen the bad, all right? And if you have those individually wrapped and obviously sterile dressings, that is that's how you make a reputation, all right? So I can tell you 100%, I'll tell you what I don't do really well. This is what I do well. It's also what gave, that's how I became a chief in the Navy, is taking care of small wounds. I'm really good at blister care. So this thing right here, it is noticeable with a fireman watching you, your EMT or paramedic partners, the nurse that you're turning them over to, all of those people, this will contribute to you having a better reputation, but also you'll feel better when you go home knowing that you did something that most paramedics don't do. Most paramedics do not do that. And I wish I could tell you I've saved many lives doing this, but it's absolutely not true, right? It didn't make that big of an impact. If you want to talk to National Safety, you want to look at research, it made an impact, but it didn't really make an impact. They got antibiotics for all of that kind of stuff. You will like the job better if this is where you focus. So one more thing that I like to bring up for this this one is this used to be, they really figured at around the turn of the century. Most of you, some of you weren't alive.
We talking about 1900 or
2000? So when they're making the new curriculum, they thought we as paramedics were going to do this what became community paramedicine. And one of the things we'd be doing is going to patients and doing wound assessments. All right, so it's a big part of our thing. You can see it in our chapter. Like they'll talk more about keloids and hypertrophic scarring and all of that kind of stuff. And it's I don't think it's a big deal. All right, but there is one little area that I do want you to know. And you almost have to picture, to me, I picture the dermatome map a little bit. You see the way those lines go? If you Google this, you could Google tension lines. And I don't think your book talks about this much. You can correct me if I'm wrong, but I don't think it's in the thing, in the...
It's like too wide.
Yeah,
It's like how skin pulls.
Yeah, exactly. So we all have tension lines. And so if this is my sweet looking thigh and a patella, your lines go like this. If you look, people who really need to know tension lines really well are cosmetic surgeons. All right, and then they focus on the eyes and the face, and you can see them all there. Look at this. This is called old people skin. So you do this and show everybody. So, so as you get older, you lose those tension lines. My skin goes like this now, all right? Younger people, the tension lines are still good and there, and it holds your skin in place, all right? So, does everybody believe that we have tension lines? Mm-hmm. Now, if we get a laceration across this, and so the way that it will be described in the National Registry is a laceration that's parallel with tension lines, all right? So if it's parallel, it will not gap, not bleed as much. It'll still bleed, but they generally don't bleed as much. They heal nicely. And that means less scarring or the problems that you see with scarring, like a hypertrophic scar or a keloid scar. So that is parallel. If we get a laceration like this one is going to be the opposite. That is perpendicular to the tension lines. It will gap. They're known to bleed more. They don't heal nice. They're prone to like a hypertrophic or a keloid scarring. So it's like hypertrophic scarring is actually your scar is bigger than what the wound was to begin with. Tension lines. About 3 times ago when I took the National Registry, they had a question on tension lines. So I was like, God, why don't talk about tension lines at all? So that's when I started talking about them. I still haven't added them to my presentations. But the last time when I took the National Registry, I didn't see any that matters to you at all. Those are lacerations. It's a jagged, usually when it's a smooth cut, it's called an incision, all right? And then jagged cuts are usually lacerations. Ooh. I think that little thing was to talk about tension lines, right? So separate various layers, an avulsion. So when we have an avulsion, this one's a dirty avulsion. Again, it completely makes sense. If they're not bleeding to death or in shock, we wash that out. And then this is the right answer. We're supposed to put it back in the anatomical position. We don't cut, never will the right answer be cut that extra tissue off the patient's body, all right? We put it back in the anatomical position, wrap it up, probably with a big dressing, and then maybe splinting is a good idea. So kind of look for splinting in that same thing, so you have less movement of that extremity. Animal bites are bad. They have fairly virulent bacteria, and some of them. Human bites are worse. We're not supposed to take penetrating objects out. That's good EMT stuff, right? When do we take a penetrating object out?
Like CPR or the airway.
CPR and airway stuff, and removing it will help with CPR or airway stuff. Then we can remove them. What would happen if we removed that nail? Like, why don't we just remove that nail?
I'd be more concerned with nerve damage than bleeding or anything like that.
Well, and someone's going to take that nail out, right?
Probably more holes for germs and everything to get in.
Yeah, we're gonna. That's antibiotics. We're gonna bring them in.
Stopping bleeding?
What's that?
It could be stopping bleeding.
It's his finger.
I know, but it was a difference.
What's another good reason? Besides getting in a lot of trouble. Pain, right? So at the hospital, they'll numb that up and then pull it. So it's pain, really. Same thing with this one here. Like with this here, it's just a bad splinter. They don't want us to pull that out either, right? It's just at the hospital, they'll numb it up and pull it out. All right, maybe numb it up and pull that out. This could be touching or breaking in and causing some blood wear, but at the hospital, they don't x-ray it and they just pull it out, right? But they're gonna probably pull it out in a more humane way. We should know, you got stuff sticking out of the abdomen, sticking out of the legs, sticking out of the chest. We're trying to mobilize it in the place where it's at, and that's it. It's kind of very EMT-ish, right? Ooh, I think we might be on the last one. So here we have some guy who ate sausage and it ended up exploding out of his stomach. What do we do for an evisceration?
Just cover it, put it over it.
What was that?
Wet a towel or something, put it over it.
Wet a towel, put it over it. And what else we got?
I keep it warm.
Keep it warm. What else?
Keep the dressing loose.
The dressing loose.
Like you don't want to compress it too much.
We don't want to push it back into the stomach.
Yeah.
Moist, and then you can do dry on top.
Moist and then dry on top. There's one more word in there. It's a word. It's truly civilians jumping on because the military does it. In the military, the patient may have to wait for everyone else, because is this guy alive, do you think? If this is his only injury, is that guy alive?
Yeah.
He's got pretty good color. I think he's alive, right? If this happens to you, just that. How do you die? Why do you die? Infection. A couple days, right? You're not going to poop very well for a little bit. So you don't, that isn't a hemorrhagic shock and you're going to die if this is really the only trauma. So that guy, if we're triaging, may have to sit there for a little while. And so they say put an occlusive dressing over it. And so a lot of times people think it's an occlusive dressing, today they said it, so air doesn't get sucked into the wound. You're not going to suck air into that wound, all right? So the idea of we said towel, but let's put an adjective before the towel. What would be the best towel? A blank towel, yeah,
Sterile.
good. Sterile and moist. You're right with moist too. So the best thing is the abdominal dressing, right? The abdominal dressing, and we're gonna get it wet. What should we get it wet with?
Sterile water.
Where are we gonna get sterile water?
Cabinet.
Good. So when can you picture the abdominal dressing? What container does it come in? Is it paper or plastic, rubber, wooden?
I think ours has a plastic side and a paper side.
And a paper side, that's 100%, right? And then some of them are plastic on both sides. So if you cut that, take a saline bag, like you're gonna start a liter of saline. The person who orders your stuff doesn't like this plan. Cut it and then just dump the water into there. All right. Now what you're gonna do is with that saline bag, you're gonna cut it, and cut it. And now you have a big occlusive dressing that's sterile, right? So everything is sterile now. The best way to treat this is to put this stuff into a yummy taco, all right? So you want that dressing to be underneath it and over it. So again, what I'm talking about truly, this is the way the military says. So it's what we say to them. If that person has to wait for a long time, if we just stick this to his thing, that's sticky stuff, all right? So it's gonna stick to the skin. And then you're gonna have to pull it apart from the skin, all right? So that's not a big deal. But the best way to do this is underneath it and over the top of it, cover everything with your IV bag. And that can be taped on all four sides. And it can be just held in place by clean too. Remember, we're not trying to do this in a way that no air can get through the wound and give him what would that be, a pneumoabdomen. And remember, how quickly does stuff dry out? It's like, are we in an environment where it's just going to evaporate and go right away? So if we're just talking about it happened here, wetting it down and bringing him to Butterworth. They don't set him in triage area for a long time and wait for him to, ding, ding, hey, I need help here still. I don't know, Butterworth might do that, but if you're brought to Trinity, he'd be seen right away. So you don't waste too much time on scene making this look pretty, right? Waste time on scene washing someone's calf. This guy, you don't want to waste too much time on scene, right? He's probably in some pain. He probably has other things going on. He's probably stabbed. This is how this happened. So you don't want, it's still going to be priority one. It's penetrating abdomen. So you're going to be talked to about your on scene times. Everybody good with that? Yummy. All right. When a good way to go is if you're laying them prone, what should we do with the legs? Bring them up. If their legs are straight, it increases the pressure in the abdomen and more guts are going to come out. So bring those up, and then if you put a SAM splint underneath them, and then just bring up the edges, what you can do is with just clean, just go boop, 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 boop. Like there's an anchor point here, anchor point here. What's that? Like a girdle? Well, I don't know, I don't wear girdles anymore for years, but so if it's coming up like this, right? This is an anchor point here, anchor point there, and then it's just like, you can just go with the cling around it, and that will be enough to keep that thing on and dry and in a sterile environment. And you might have an evisceration on Wednesday. And then an open neck. An open neck we'll talk about a lot more when we get to neck injuries, but what do we do for a neck wound, an open neck wound? So with this here, what would they want us to do? And you know what our protocol says? Appropriately manage open wounds, soft tissue injuries. That's all it says. It doesn't tell you how to. What do you think? So this would be sterile dressings against it, and we again have, for neck wounds, we're supposed to use occlusive dressings, all right? Because they say neck wounds, you can pull in air also. So this is actually called a region 3, right? A region 3 neck wound is one that, like the TMJ, what is that? That's TMJ. Everybody's good with that? The corner of the jaw. And the chin, when we go like this is the third area. The first area is way up by where our traps and our clavicles are. So this is like area 1, and this is area 2. When we're way up here by area 3, what I'm talking about has a limited value. All right, so with that one, I don't think I would do an occlusive dressing, and I don't think I would get into trouble. I would try and get that all nice and comfortable, and maybe put a C-collar on them to help you put some pressure there. Zone 2 and zone 1, the theory behind this is, as they decrease the pressure in their chest, if they can suck air into their chest from here, from outside, if it's open, and you don't know if it's open or not, they can suck air into their chest. If their jugular vein is cut, you can suck air right into the jugular vein, goes to the right side of the heart, and gives you a pulmonary emboli, air emboli. Make sense? So, and then they just give us a blanket statement. We do, manage the tissue, and then cover it with an occlusive dressing. And then occlusive dressing could be, again, an IV bag. It could be anything that you can, like the bag that we have for our non-rebreathers. All of that's supposed to go over the top of everything. Hold it in place with whatever you can. Good. Why does it say cardiac arrest? Open neck injury can be life-threatening. Just give you cardiac arrest. It's bad. So crush and blast, we've already talked about these enough, right? Primary is about the pressure, and then secondary is going to be shrapnel. Tertiary is your body getting thrown. Closed injuries, we're going to treat with RICE, right? Rest, ice, compression, elevation. ICE says is going to be splinting. And I like ice. All right. Any questions about closed? And then the next one is amputations. For amputations, when we have that, is this a hand? Looks like it, right? So when this hand gets severed, what do we, let's say it got severed in that farmer who didn't know how to drive a tractor very well. It's his hand that we just picked up out of the soil. What do? Split the hand?
Well, oh, is it completely or partial?
No, it was over there.
No.
Complete.
You bring it with you.
And tell me more.
Put it back.
Maybe clean off the dirt first.
Yeah, we should brush off and we can wash off. All right, we can wash that off, but we can't let it soak in water. So water isn't bad. Soaking in water is bad. So we can clean that off, and then we should wrap it in, clean or whatever you want to. I say put that in a Ziploc bag or whatever you have, and then put that into a Ziploc bag or whatever you have. It's probably like the biohazard bags, and then put that into ice water. You're not supposed to set it on ice. Like it will freeze tissue, right? You just gave them frostbite, all right? He's having a bad enough day. So today we talked for a while about will they reattach it, all right? And at least in the 90s, and just recently somebody said, yeah, Butterworth just did a reattachment. No, he didn't say Butterworth. He said they did a reattachment here though, in West Michigan. Butterworth used to have a guy. He would do talks. He was like, I want to say world renowned, or like, let's say known all over the country for being a hand doctor. Do you guys know his name? It's Dr. Hand. So that's a true story. So I think Butterworth can do it, but some people are saying no, Butterworth doesn't do it anymore. But they do fly people to U of M Ann Arbor, where they reattach hands and feet and things of that sort. People usually don't reattach fingers anymore. That's why there's so many stumpy looking people out there. So you have so I would still say we don't make those decisions, right? That's above our level. So if
Couldn't find it.
you couldn't even find it, so it wasn't that you were just hungry. It followed you around with a bag for a while. So if you get your fingers cut, we should do all of this stuff. Wash them off, put them in a thing, and then tell the patient, probably not going to put it back on. All right? I don't know. Maybe they will, but
They said to make
they
it work,
usually
it's
don't.
gotta be past the first digit. So.
Past the first digit.
I wasn't quite there.
And then for the hand, whether Butterworth does it or not, I kind of think Butterworth does. They will at least fly to Ann Arbor, and Ann Arbor will do it. Many questions with that? Wash it off, wrap it up, keep it dry and cold. And then how long do they have to reattach it, you think? Yeah, 4 hours, 6 hours. If we keep everything cold, it might go out a little bit. 4 hours is probably a good amount of time, right?